Okay, this next section is about medications that are used for chemotherapy. And so oftentimes they're talked about along with immune medications because they do heavily affect the immune system, at least the function and the number of white blood cells. But chemotherapy drugs are meant to stop cancer. So the idea is that cancer cells or cancerous tumors are made up of rapidly dividing cells. They don't respond to any of the body's normal limits on cell growth. They would divide and divide forever. And they divide very, very rapidly. And so all the medications, a lot of the medications that are used in order to battle cancer stop or don't allow for the rapid division of cells, knowing that cancer does that. So you'll see on slide 18, there's a picture of the cell cycle and the phases that the cell goes through, where first sort of doubles up the contents of the cell, checks for any mutations in the DNA as it replicates, gets everything lined up in the center so that it can pull apart. Again, checking things over, then it pulls apart. All those different phases are different times that the cell could potentially be interrupted and not allowed to divide. And that's why there are many types of chemotherapy medications are trying to target different parts of cell division. That's definitely how the first chemotherapy agents were done or used or created. So all chemotherapy medications have the side effects related to the innocent bystander rapidly dividing cells. So we wanted to target cancer cells that divide rapidly, but there are other cells in the body that divide rapidly, and those are the ones that will take a hit during chemotherapy and why the patient might feel very sick, depending on which agent it is. So the bone marrow is a part of the body where there's rapid cell division, so we're trying to replace white blood cells, red blood cells, and platelets. So any chemotherapy could cause a lowering of those cell lines. The patient could have GI upset for sure, including what's called mucositis, or sometimes referred to as stomatitis, where they get sores in their mouth. So the cells of the mucosa are inside the mouth, all the way down the GI tract, again, are rapidly dividing cells. So you can get sores there, or they will have lots of shedding of cells, which will lead to diarrhea and not feeling very well. And also these chemotherapy drugs can affect the vomiting centers in the brain. People lose hair. Hair follicles are a constant state of transition. That's another possible side effect, and that's alopecia. Sperm cells and the reproductive tract is another area of rapid cellular division, so people can develop infertility. Hyperuricemia, we talked about that before, that different chemotherapy medications change the way the body handles uric acid and does increase the potential for elevated uric acid, which could mean gout. So sometimes those patients are on medications daily to suppress that. Most chemotherapy agents will be at least a pregnancy category D and require contraception during the time of chemotherapy. And all chemotherapy agents could also harm the person that is going to give them. So it usually requires special training. Sometimes these are a group of medications that are just like some of the other ones we talked about, that are vesicants that can cause damage to the skin if they get out of the IV line. So it's best that you use a larger bore IV, that you stay away from joints. But the best scenario would be to use a central line, like a PICC line or some kind of port. If you're handling chemotherapy agents, you have to dispose of them properly and wear proper gloves. It's a chemical spill if this agent gets spilled. And so now we're just going to talk about a couple of chemotherapy agents, and they're much, much more than what will be on your exam or what we're talking about. So the first one of the first chemotherapy agents that was actually developed is methotrexate, because it manipulates folic acid, and folic acid is very important for rapidly dividing cells because you need it in order to help with DNA synthesis. So we talked about methotrexate as a medication that someone could take weekly for autoimmune diseases like rheumatoid arthritis. We talked about it as a medication that someone could take to suppress their immune function if they're trying to prevent organ rejection. At higher doses, you could use methotrexate as a chemotherapy agent to help stop cancer division. However, that's its highest dose, and so people are more likely to experience some of the side effects, especially the stomatitis and bone marrow suppression and pulmonary fibrosis when taken as a chemotherapy agent. The bone marrow suppression can get so bad that they might need to take an antidote, a medication to reverse the effect, and that's leucovorin. This is the same medication as pregnancy category X that you have to continue contraception while you're on it, as well as 6 months after. So this is can definitely be hard on the person. Another agent, which is in a group called alkylating agents, that's cyclophosphamide, which is close in name to cyclosporine, so don't confuse them. Cyclosporine is the anti-rejection medication that we talked about that has the high rate of fluid retention and hypertension. Cyclophosphamide is a chemotherapy agent that causes DNA to have abnormal crosslinks, and that will end up creating a defective cell, which will die. So we have to worry about all those things, how to protect people from infection. What about, the GI side effects, hair loss, being sure that it's given properly, all those things we have to worry about. This has an additional problem with high potassium and low sodium. You can take it orally, but without food. The other thing that you see there that's listed says hemorrhagic cystitis. So we talked about like rifampin and some medications creating a color change to the urine. This is different. This is actually causing inflammation to the bladder wall, leading to bleeding. So the patient will pass blood. This is much more dangerous. Not only could it be painful, but if the bladder, inside the bladder bleeds, it could form clots, and those clots could make it impossible for the urine to pass. The people will have urinary retention, which can be kind of dangerous. So the patient who's experiencing hemorrhagic cystitis might call you and say they're passing blood and clots in their urine, or they have to urinate very badly and they cannot. The way to help prevent hemorrhagic cystitis is to drink lots and lots of fluids and be very hydrated, because then you dilute that medicine as it's being excreted and can protect the bladder wall. So that's important to remember for the exam. Cisplatin is a different chemotherapy agent. That medication causes abnormal crosslinks in DNA, similar to the cyclophosphamide, just a slightly different mechanism. This tends to have more severe GI side effects. It's kind of the one that people think about when they think of chemotherapy, where you're just vomiting as soon as you get it. So usually people are pre-treated to prevent that. Nephrotoxic, ototoxic, so that means it can hurt or kill the kidneys. It can cause damage to hearing or balance. People can have severe allergic reactions to it, so you have to keep treatment on standby for anaphylaxis. This is only an IV medication, so it would be administered, and then the patient would leave. And then you're going to see something there. It says nadir, 18 to 23 days. So this is something that becomes important twice. Once we're going to talk about it during chemotherapy agents, but we're also going to talk about it during agents that are used to help stimulate growth of cells in the bone marrow. So a nadir, what that means is lowest point. Like an apex is the highest point, a nadir is the lowest point. So a lot of chemotherapy agents that are notorious for causing bone marrow suppression will have their lowest point, meaning the patient's bone marrow cells will be knocked out, or they'll have their lowest white blood cell count, red blood cell count, or platelets at a certain predictable time period. So when a patient gets their first dose of cisplatin, that's day 1. At about day 18 to 23, we can expect that they will be at their lowest white blood cell count. Well, they'll be at the biggest risk of infection. Some people can be so neutropenic that they might have 0 white blood cells, and they have to be protected from infection. So different medications have different nadir points, and cisplatin says 18 to 23 days. What this comes into play is that a lot of times patients will be given colony stimulants or growth factors, which are medications we're going to talk about this unit as well, in order to beef up their white blood cell, red blood cell, and platelet counts, especially white blood cell counts, before they get to the nadir. Because someone with a white blood cell count of 0 is very easily can get infections, but their own body can give them infections. Just their GI tract accidentally could give them an infection. So we want to protect them. So if the nadir for cisplatin is at 18 days, and we know that the patient will probably have their lowest white blood cell count, then a couple days before, the patient might go to the office and get a dose of Neupogen in order to beef up their white blood cells so that it starts to climb before they hit their lowest point. And so this will come up again. So it's coming up with the next medication too. So doxorubicin, this is an anthracycline. It's actually an antibiotic that kills tumors. So doxorubicin works by decreasing DNA repair and stops the division of cells. This also has issues with allergies. The nadir for doxorubicin is a little bit quicker than cisplatin. It happens in 10 to 14 days. So I give the medication on day 1. By day 10, I can expect that the patient will have their lowest white blood cell count. It's possible that they'll be given medication to try to avoid that a couple days before. Extra issues, we always have to worry about vesicants. We always have to worry about opportunistic infections and immunosuppression. We have to worry about the GI tract, all those things, proper handling, all those things always with chemotherapy medications, but there's a couple extra things here. This one is notorious for causing hepatotoxicity, which is liver disease, as opposed to cisplatin, which was nephrotoxicity and ototoxicity. This medication can cause cardiac toxicity even years later. And I've had patients who were on anthracyclines or doxorubicin for breast cancer or other types of cancer, and 10 years later they developed heart failure. So gotta be sure we understand the symptoms of heart failure. So that means the fluid isn't pumping forward, so you got extra fluid in your lungs or in the system, in the legs. This one can cause fluid discoloration of the tears or the urine. So red urine, different than cisplatin. So if somebody was on doxorubicin and called me and said they had red urine, I'd be like, oh, that's that medication. And sometimes to help me remember that, I think of rubies, doxorubicin, and rubies are red. So there might be fluid that turns red. As opposed to someone who's on cisplatin that called me and said, I'm sorry, not cisplatin, if they were on cyclophosphamide and called me and said they had bloody or red urine, I would be more concerned that it was actually bleeding itself. Next medication that's in this group are taxanes. So these are also stopping the division of rapidly dividing cells. Our prototype is Paclitaxel. Again, issues with allergies. This one is IV and it has to have special tubing. Patient is pre-treated, which happens a lot with different chemotherapy drugs. They often have changes in their heart rhythm, especially bradycardia, so they'll probably be on telemetry while getting this. They experience their nadir at 11 days. So you give a medication, I would expect at 11 days they'd have their lowest white blood cell count. So I would probably give them a medication a couple of days before to help alleviate that. The other huge issue with Paclitaxel is neuropathy, numbness and tingling to hands and feet. Sometimes it can get so bad that it's actually not just numbness and tingling, that it hurts. and the patient can lose fine motor. I've had patients that are unable to, hold a pen anymore and write because of this, and that can sometimes be a reason why they would stop taking it for a while. The last two medications that we're going to talk about that are chemotherapy agents, technically, because they're medications that you take in order to get rid of, and that affect systemically to get rid of cancer, are medicines that block hormones, specifically androgen receptor blockers and estrogen receptor blockers. So, an androgen receptor blocker medication, our prototype is flutamide. And so the thought is that if sometimes people get prostate cancer that is sensitive to androgens or testosterone, meaning there's receptors on top of the cancer that when testosterone or androgens are present, they increase cancer cell growth. So if I block that receptor, like this medication does, flutamide, then I can decrease cancer growth. And so oftentimes people will take this prolonged to prevent any, say the person went through prostate cancer treatment or they have a really small tumor, so they're just sort of watching it. We want to be sure if any cell flipped off to travel someplace else, if that cell's receptors are blocked, it won't grow and set up shop and create a metastatic tumor someplace else. So this medication is given by mouth 3 times a day. It can, because it's blocking androgens, cause breast tissue growth and hot flashes, cause impotence or decreased libido, and its biggest issue is liver toxicity. So we know that's the blood tests are ALT, AST, and bilirubin, and we're looking for abdominal pain, dark urine, light stool, jaundice type of symptoms. So this person might be on this medication for years in order to prevent regrowth of their tumor. Another example is tamoxifen, which is an estrogen receptor modulator. It's not just a blocker. And that should sound familiar to you because that was one of the osteoporosis medications we used, was an estrogen receptor modulator, raloxifene or Evista, because these medications block estrogen in some places and activate estrogen in other places. So Evista or raloxifene activated estrogen in the bones, which helped decrease osteoporosis. Tamoxifen does that too. It does decrease osteoporosis, but it also blocks receptors, cancer receptors in breast tissue to decrease growth. Oftentimes, people who have had breast cancer will go through their surgery, radiation, and chemotherapy, and then be on tamoxifen for 5 to 10 years afterwards, in case any little cell flipped off, will block its ability to grow by giving the tamoxifen. So this pill is taken 1 to 2 times a day. You have issues with hot flashes, and potentially it can cause retinopathy, so they need eye visits to be sure that they're dilated eye exams to be sure their eyes are okay. It acts like estrogen in the uterus. And so if a patient does not have their period anymore, so they don't have withdrawal bleeds, and they still have their uterus, they're at increased risk for endometrial cancer. So they'll need to be sure they're following with their gynecologist. And just like any medication that promotes estrogen in some places, and just like raloxifene, we have to worry about DBT or PE as well. So then on that set of slides, you'll see there's some other medications, and these are really targeted therapies where we're looking at specific cell inhibitors or antibodies. Those are on the ATI, but they will not be on our exam, so I'm not going to talk about those.